Hello and welcome everyone to tonight's webinar, the second in the series on cardiac care in the ACT. This webinar covers GP management of acute and chronic coronary syndrome, initial presentation and post-discharge follow-up care. I'm Dr. Leonie Harcourt, a GP education advisor at Capital Health Network. Also with me tonight is Kanal Mohiti, the events lead at Capital Health Network, and of course our expert speaker, cardiologist Dr. Siang So. And also just a plug for next cardiac webinar, which is on the 6th of August, where Dr. Sharon Wilson will cover heart failure. So first, we'd like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Island people who may be attending tonight's event. As usual, all attendees have been muted, and if you have questions, please type them into the Q&A box of your Zoom window. Siang has kindly agreed to answer questions throughout his presentation. So when they're relevant to what he's talking about, we can interrupt him, or I'll interrupt him and read out your questions. So that's the procedure for the Q&A tonight. And please feel free to report 1.5 hours of educational activities to your CPD home. So Dr. Siang So is a general cardiologist and he's worked in Canberra for quite a while. His private practice is in Deakin, and apart from cardiology, he enjoys gardening, which is a great pursuit as long as it rains. And he also enjoys teaching, and I think you'll see tonight that from his presentation that he's got a special skill in that area. So thank you very much, Dr. So, and just handing it over to you now.
Thanks, Leonie, for your kind introduction. And hi, everyone, for joining us tonight. So the plan for tonight is I'm hoping to finish this talk about 45 minutes to an hour. And you can ask questions as you go. But I'm hoping to leave plenty of time for discussion at the end, because this is a big topic and something that we see day in, day out, and it's very common. And what I'm going to do is to build on a lot of knowledge that you already have on your day-to-day practice. But I'm going to provide some quick update based on the latest guideline and the current evidence. And I'll emphasize some of the subtle, important differences between how certain decisions are made. And if you have any questions, please feel free to send me an email after the session. And if there's any question in the future, I'll be more than happy to answer them as well. So the topic of tonight is GP management of acute and chronic coronary syndrome, the initial presentation and post-discharge follow-up care. I think to emphasize this is really have a clear idea of the difference between acute coronary syndrome and chronic coronary syndrome. And so when I was a registrar, I used to think, if I know all the cardiology guidelines, that's all I need to know. And after 7 years, 8 years of practicing as a consultant cardiologist, and what I realized is how do you apply that guideline and tailor them into the individuals in front of you? That is the actual skill. The knowledge itself is available widely. And nowadays, if you just type in a key question, Google can answer that for you. But how do you make a decision with the patient in front of you? I think there's a lot. This is the clinical skill that we all hope to achieve very well. So without further delay, I'm just going to start the talk. So the original talk was about how to manage the acute presentation of acute coronary syndrome in the GP setting. So from my point of view, the Australian clinical guideline actually just being published this year in 2025. They make a very simple summary for us, which for people with suspected acute coronary syndrome initially evaluated in the primary care setting, a prompt transfer to a facility where definitive risk assessment can occur, most commonly emergency department, is recommended. So if you see a patient with ongoing chest pain that you worry about being angina, what you need to do is just call an ambulance and get them across to the hospital. Those patients who had chest pain the same morning when they come and see you, that takes a bit of a trick. If you believe the chest pain the patient had this morning is angina, I will still believe sending them to hospital might be the right place to send them to. So otherwise, if you, lucky or unlucky, have a patient in the room that has acute chest pain that you think is having angina, again, call an ambulance. First thing, if you have, is give them 300 milligram aspirin, make them to chew it. And if you have a GTN spray, that will come in very handy. If their oxygen saturation is above 90%, actually there's no indication of giving oxygen supplementations. If you have a chance and you can check their blood pressure, if the blood pressure is below 100, you have a sick patient in hand, and you have to ask the paramedic to hurry up. And while we are preparing for their arrival, I think having the resusc trolley or defibrillator at least standby will be a very good idea. And if unfortunate event occur, then BLS is what we need to start. And 30:2 ratio is all we need to remember until the help arrive. ECG, I mean, in the very chaotic environment, it might not be the best thing, but this is probably the first thing that the ambulance officer would do when they arrive as well. So this is a very simple strategy. Just manage a patient acutely until you can get the help you have. So again, when we talk about acute coronary syndrome, vast majority of them are related to the acute plaque rupture and the thrombus formation that occlude the coronary arteries acutely. That's why we call them acute coronary syndrome. As compared to the chronic coronary syndrome, where most patients may or may not have a fixed coronary artery disease that may or may not causing any significant symptom. So the immediate post-acute care or post-acute coronary syndrome care that you may see is after the patient has presented to the hospital and returned after a few days in hospital stay. What is important though is a quick flip through of the discharge summary from the hospital. As you and I know, the quality is quite variable. In general, what we really like to know from them is, was it a STEMI or a non-STEMI? And which artery was fixed? Was it a balloon angioplasty? Was it a drug-eluting stent? Or was it a bypass? And how complex was the disease? It's quite different when a gentleman had one single mid-LAD stent that was stented with a drug-eluting stent compared to someone who had triple vessel disease and had multiple bypasses or multiple vessel that was stented with potential complications. So that will actually set the scenario of potential things that we watch out for. And also quite helpful in the discharge summary, have a quick look to see whether there's any significant complication that occur in the hospital. Because if the patient has a heart block after infarct, then of course, bradycardia is something that we'll watch it out. We have to keep a close eye on. And if the patient have any kind of vascular or bleeding complication, that actually increases the patient mortality. Again, you are dealing with potentially slightly higher risk of group of patient, or if the patient has heart failure by the time they presented to the hospital with acute coronary syndrome, again, these are your potentially sicker group of patients. So nowadays, it's kind of expected the patient coming from the hospital, they should have some degree of assessment of the LV function. The LV function would determine how concerned or worried we are in terms of the potential the patient prognosis. And other thing that we do look out for using an echocardiogram is the potential complication for the actual infarct itself, such as functional mitral regurgitation, and did the patient has a tamponade or pericardial effusion, and something what we call aneurysm of the left ventricle. When the left ventricle wall is significantly infarcted, then become aneurysmal, and there has an increased risk of rupture. And there's also risk of LV thrombus formation when you have aneurysmal segment of the left ventricle. Finally, which is probably the most important thing, is to have a quick look on their medication list. So the key thing about here is asking the question, what is missing? If something is missing, is there a reason for it? So nowadays it's very uncommon, but even when I was a registrar, sometimes we have seen incidents where patient gone home and they actually do not have the dual antiplatelet that's supposed to go home with them. And hopefully this no longer happen, but simple things if we miss, and that has a bad consequences. And finally, is the patient in front of you? How are they feeling? If they are usually feeling pain-free, they are not too breathless, things are moving in the right direction, that is reassuring. As compared to some of the patients have ongoing chest pain, especially those with nighttime chest pain or additional chest pain. Those are the patients that potentially worries me, whether or not the stent has some issue, or is there any residual problem that we haven't fixed? And if you have any of those complicated patient, and usually in your referral, then it will be good to flag this patient probably should be seen earlier rather than later. Earlier, as in within a week or two after the hospital discharge, so that we can assist with their transition of care. A lot of patients, post-infarct with no complication, waiting for 4 to 6 weeks is not an unreasonable thing to do. But again, every individual is a bit different, and how complex this patient in front of you is will determine how urgent they need to see us as a cardiologist. So the second part of the talk, I'm just focusing on the routine care post-acute coronary syndrome. This is not very different between when I see the patient as well. And I suppose we all can do a similar job. And this is just a common routine that I go through in my head when I see this patient. The first thing I want to do is to make sure they are on optimal medical therapy, which I will cover in details of the drugs that I expect them to be on. And if they are not on, and there must be a good reason for it. Otherwise, the patient is not receiving the best available therapy. Compliance, I think this is probably the difficult thing in the long term, which I will touch on a bit later. And also remind the patient they should make sure they go and attend the cardiac rehabilitations and the lifestyle changes, which I'll leave it at the end to discuss because they are quite practical. There are lots of patient questions, especially when they first have the MI. So I think among them, I want to emphasize the importance of cholesterol lowering therapy. So in patients with established atherosclerotic cardiovascular disease, we know as a fact, lowering the LDL cholesterol reduces the risk of major adverse cardiovascular outcome. Because patients with chronic coronary syndrome, they already have the initial cardiac event, they are considered extremely high risk of having future problem. So therefore, not surprisingly, nowadays, the European Society guideline and as well as the latest Australian guideline, we want our LDL cholesterol target of less than 1.4, and or at least achieve a reduction of their baseline cholesterol by about 50%, if not more. This is based on the European guideline. For patients who experience a second vascular event within 2 years while taking maximum tolerated statin therapy, we may even aim for a lower LDL target of less than 1. So of course, exercise, diet, weight control that can favorably affect the blood lipid level are recommended, but those are harder to achieve. But committed patient, that will make a big difference as well. Importantly, what I like to describe to the patient about the importance of statin is that in the landmark meta-analysis that we had, we know use of statin reduce major vascular event by 22%, mortality by 10%. And this is the number that I like to quote in a general basis. Every time we reduce the LDL by 1 millimole per liters, we reduce the relative risk of mortality from coronary artery disease by 20%. This is how powerful this marker is. And that's why the cardiology guideline keep dropping them from 2.6, 2.2, 1.8, now 1.4. To be honest, is not, I won't be surprised in a few years' time, we're going to aim for LDL level less than 1, because that is the trend. And we emphasize the importance of high intensity statin therapy at the highest tolerated dose. So what we mean by that is atorvastatin as a minimum of 40 milligram and rosuvastatin as a minimum of 20 milligram daily. And I always emphasize that if the patient is tolerating the statin, please do not reduce the dose. Even though your LDL drop below 1, that will still be quite a safe thing to continue. We know the higher dose of statin has a better plaque stabilizing effect. That in itself is a crucial property that reduces a patient's chances of having future acute event. I always explain this is exactly the reason why when the patient presents acutely to the hospital with acute infarct, we give them 80 milligram of atorvastatin or 40 milligram of rosuvastatin to stabilize the plaque. If we can achieve that, that is a big achievement. But we all know the problem with statin is its potential side effect and the reputation problem it has. So not uncommonly, we all have to deal with the potential side effects such as myalgia, myositis. Some patients have liver dysfunction, and general other non-specific symptoms that are attributed to statin. So if the patient cannot have statin, then our fallback is this medication called ezetimibe. They come out from the IMPROVE-IT trial where patient post acute coronary syndrome, when ezetimibe was combined to simvastatin in the original trial, the additional ezetimibe did result in slight improved reductions in terms of cardiovascular event. But as we all know, ezetimibe is a weak anticholesterol therapy. The level of reduction of LDL is nowhere near statin. So once we don't have a statin, we are on the back foot using just ezetimibe. So the third group of this medication, of course, is the new kid in town, and everybody loves them. But I'm going to caution very seriously about this medication. Use it wisely. This is a very helpful therapy to have. I do like to use them when I really struggle with patients that can't have statin. But if your patient can have statin, we will be doing them a disservice by prescribing them this new drug and ask them to stop the statin. The reason I said that is because all the trial and all the data that we have about the usefulness of PCSK9 inhibitor is built on the good evidence of statin and ezetimibe. And this is used as an adjunct therapy or additional therapy on top of those drugs. So therefore, use them by itself, their effectiveness may not be that good as we expected. So therefore, the right things to use this medication is patient on maximum tolerated statin and ezetimibe. If the LDL is still significantly elevated in some small amount of patient, then adding the PCSK9 will be the right thing to do. So usually on the previous criteria, the LDL has to be more than 1.9 for us to add in this particular medication. And they also have a criteria of multivessel disease or patient have significant one vessel disease with other vascular problems such as peripheral arterial disease or a stroke in the past. So it is a good drug, but as you note here, the outcome data of the evolocumab, which is the only immunoglobulin that's available in Australia now, only achieved significant reduction in cardiovascular outcome. The mortality data is actually not that robust. Same as inclisiran, the outcome data of the trials actually has not been finalized until next year. So we're using it because we know they are effective in reducing LDL, and we are making assumption if we can achieve the LDL reduction, we can achieve the same outcome. But this is different compared to the huge body of evidence that we have for statin. Moving forward, we're now focusing on antiplatelets and anticoagulant. So there's no new drug. We are all very familiar with it. I just want to clarify what we do. Patient with post-acute coronary syndrome, be that in unstable angina, non-STEMI or STEMI, they all should have dual antiplatelet for 12 months in general. So that's a rule of thumb. We usually don't reduce the duration unless patient has bleeding complications. Of course, nowadays we have lots of patients with atrial fibrillation. In those situations where then we put a stent in, then initially these patients need what we call a triple therapy. So usually it's a combination of aspirin, clopidogrel, and one anticoagulant, usually apixaban or rivaroxaban. In this situation, we try to avoid the more potent platelet, such as ticagrelor. We generally do tend to use aspirin and clopidogrel in that sense because the triple combination are a very powerful combination to cause bleeding. And usually in that circumstances, we use aspirin for 1 to 4 weeks and the maximum of 4 weeks in the initial period. If the patient has high risk of bleeding, sometimes we just keep the aspirin for 1 week. And clopidogrel after that is usually for 12 months. unless again there's any bleeding problem, and the anticoagulant is lifelong for the AF indication in general. Another subgroup of patient that I want to mention is the post-coronary artery bypass surgery. Even without acute coronary syndrome, usually even without acute coronary syndrome, our local surgeon like to use 12 months of dual antiplatelet to preserve the graft patency. I must say this is a bit of surgeon dependent as well, because some surgeons in Sydney, they're happy with single antiplatelet. But in general, if they have acute coronary syndrome, doesn't matter what kind of revascularization you do, you have to have 12 months of dual antiplatelet. As compared to patient with chronic coronary syndrome. For example, patient have stable chronic disease and start having a little bit more adjunctional angina. In that context, we identify a severe stenosis that we need to put a stent in. In that context, usually the dual antiplatelet are usually about 6 months in duration. But usually the intervention cardiologist or the cardiologist will specify and how long they want to keep the antiplatelet for. And most importantly, and very practically, if patient have acute coronary syndrome, generally speaking, we would like to avoid surgery and anesthetic within the first 3 months. Because the risk of recurrent acute coronary syndrome is the highest within the next 3 months. And afterward, the risk will plateau and reduce over time. However, if the patient need life-saving surgery or cancer surgery that we want to prevent metastasis, then sometimes we can bring the surgery forward, but usually we'll still keep as a minimum of 6 weeks post-event. So in the longer term, after 12 months of dual antiplatelet, what should we do with a single antiplatelet? In general, most patients would have single antiplatelet as a maintenance. Conventionally, majority of patients currently is still just remains on aspirin. This is used as a secondary prevention, so they are not to be confused with the primary prevention indication where patient has not had a vascular event. However, interestingly, the last few years, there's a shift of thinking about how aggressive we should be with the long-term single antiplatelet. This trial that I mentioned here, they're comparing aspirin and clopidogrel over long term and found that there's some small benefit in reduction in ischemic event using clopidogrel compared to aspirin. And subsequently, there's a meta-analysis combined quite a number of different trials. And they also identify and suggest the P2Y12, which is clopidogrel inhibitors, can reduce the myocardial infarct risk as compared to aspirin with a comparable major bleeding risk. So therefore, in my own practice, if I have a young patient with multivessel disease that has what I call a high ischemic burden and a relatively low bleeding risk, then I will put them on long-term clopidogrel as a preferred therapy as compared to aspirin. Actually, to my surprise, the Australian guideline actually come out suggesting they actually would suggest and recommend preferred therapy to clopidogrel in a lot of these patients in long term. So watch the sphere. This is coming up quite new. So some of us already started using clopidogrel more. You see that soon they may become a bit more prevalent. The only issue I usually warn the patient is if you're on clopidogrel and you have an acute injury, you need acute surgery, the surgeon is going to be a bit more scared. And in general, most surgeons are more comfortable operating on aspirin as compared to the P2Y12 inhibitors. And if they were to need elective surgery, I usually ask them to swap the clopidogrel to aspirin a week before, and some surgeon will allow them to operate on aspirin. So the next topic is the ACE inhibitor and angiotensin receptor blocker. So in patient with chronic coronary syndrome,
Could I
ACE or
interrupt? Sorry,
yes,
I've got a question. Sorry.
yep.
So what do you advise about patients who are going to have surgery and they're on either triple therapy or dual antiplatelet therapy in terms of stopping for surgery?
Okay. So depends on the indication and what surgery they're having, and also the patient risk. So to put it very simply, for example, with a straightforward patient with atrial fibrillation, they had a stent. And ideally, I mean, hopefully we're not talking about a patient with triple therapy because, if the patient needs triple therapy, they usually need it for the first month. That means they have a new stent. So those are the patients that's tough. If I need to stop the antiplatelet in that 4 weeks, the risk of stent thrombosis is extremely high. Usually we would request the surgery be postponed if they can be avoided. After 4 weeks, then things is a bit easier. And then usually we stop the aspirin anyway. Then we keep the clopidogrel and the anticoagulant. Again, within the first 3 months, I would like to avoid surgery. And unless if it's a life-saving surgery, then what we do is we stop the clopidogrel, put the patient on aspirin, and we negotiate the surgeon to operate on aspirin. And the anticoagulant, like apixaban or rivaroxaban, we tend to stop them 48 hours beforehand. However, with the caveat, that's provided the patient doesn't have an embolic stroke in the past. If they have embolic stroke, then we would like them to be breached with clexane or heparin before surgery. Have I answered that question?
Yes. So what GPs often get is requests from dentists about platelet aspirin or clopidogrel or rivaroxaban.
Yeah.
So, yep.
So
it's not usually major surgery. It's usually kind of dental situations.
Yeah. Correct. I mean, I find those a bit of a nuisance question, to be honest. Generally speaking, the guideline, the major society guideline would suggest a dental work, you do not need to stop the antiplatelet and anticoagulant. But in practice, most dentists will ask you to stop anyway. So if I think the patient risk is very high, sometimes I say no, you have to operate with the antiplatelet. And you just need to suture, you need to pressure, you just need more time to achieve your hemostasis before you move on, as compared to stopping the anticoagulant and the antiplatelet. So again, for my patient with AF and stroke in the past, especially when they stop the blood thinner and they have a stroke, I'll strongly advise them not to stop the anticoagulant because the surgeon actually can deal with it. In real life, in general, I think stopping the anticoagulant 24 hours beforehand should be more than sufficient for most dental work. Clopidogrel, those are the same. I mean, strictly speaking, if you really want to stop, you have to stop it 7 days beforehand for the platelet to regenerate and wash out the effect. But in real life, I mean, they usually get away with it after you stop it for a couple of days anyway. So ideally, we really don't need to stop, but in real life, we do stop it for at least a couple of days before the procedures. Yep.
And there is a question in the Q&A box related to aspirin and clopidogrel, and I think you might have mentioned in the Capri trial that clopidogrel was more effective, but just questioning whether aspirin is more effective or more potent than clopidogrel.
No, actually, in those trials where we follow up clopidogrel versus aspirin in patients who have significant ischemic burden, the clopidogrel come out on top. It has less ischemic event with comparable bleeding risk. So therefore, there's a swing towards using clopidogrel in some of those patients whom I call, high ischemic burden.
Thanks.
Yep.
Yeah, we'll let you proceed.
Okay. So ACE and ARB. So for patient with chronic coronary syndrome or patient post-acute coronary syndrome in the hospital, when do we use ACE? So the evidence is strongest for ACE inhibitor or ARB if they have hypertension, or if they have diabetes, or if they have reduced ejection fraction or in heart failure. So those are the group of patients they must go home with the ACE inhibitor or ARB for any of these indications. They have high blood pressure, if they're diabetic, or if they have heart failure. So the use of ACE inhibitor ARB is a class 1 recommendation because they reduce mortality. All right. We have a weaker recommendation to use ACE as a general recommendation. Should be considered in patient with post-acute coronary syndrome patient at very high risk of cardiovascular event. There's also some data to suggest use of ACE inhibitor is associated with a reduced cardiovascular event. So therefore, the strongest indication for patient for ACE and ARB hypertension, diabetes, and heart failure. And if you don't have any of that, it's a weaker recommendation. Therefore, not uncommonly in the hospital, as long as the patient has a blood pressure, above 110, in general, our routine practice will put them on a small dose of ACE inhibitor. Sometimes some of these patients, when they come and see you, their blood pressure become too low. If the blood pressure is, drop below 100, they are very faint and they are, very miserable. And those are the potential patients that we can stop. In general, I would like to emphasize post-acute event or patient with significant coronary artery disease. Nowadays, we like the target blood pressure of less than 130/80. So therefore, we have low threshold to use ACE inhibitor or ARB as a preferred antihypertensive in patient with coronary artery disease. Okay. So this is the latest medication. So we just have to be a bit more creative in how we introduce these drugs. So in patient with chronic coronary syndrome and type 2 diabetes, there's quite a good and strong data to suggest SGLT2 inhibitor has proven cardiovascular benefit in terms of reducing cardiovascular outcome or reducing cardiovascular event, sorry. So therefore, if your patient have coronary artery disease or acute event with diabetes, and SGLT2 will be your preferred anti-diabetic medication, and you can use it for the indication, that will be the right thing to do. The second recommendation is a tricky one, which is a GLP-1 receptor agonist. Again, we're talking about the Ozempic, Mounjaro type medication. Quite interestingly, we don't really know how it works, but all these group of medication, they tend to have quite a good beneficial effect on cardiovascular outcome as well. So therefore, these two drugs is considered by us as a safe medication to use in cardiac patients. And if the patient actually qualified to use this medication from the diabetes indication, and that will be a good thing to do. So this talk about use of semaglutide in patient with obesity without the diabetes indication. Again, we know when we use it in patient with weight issues, there's reduction in diabetes and cardiovascular mortality. Therefore, if the patient can afford them and would like to embark the journey to have this medication on board to help them to improve their overall fitness and weight reduction from the cardiac point of view, is a good thing to do as well. And finally, this is actually the new recommendation. Not so much new in Europe, and it came out in 2024. And I'm actually quite pleasantly surprised it also came out in the Australian guideline in 2025. So in patients with chronic coronary syndrome and established atherosclerotic coronary artery disease, a low dose colchicine at 0.5 milligram once a day should be considered to reduce MI and stroke and need for revascularization. As you can see, it's a class 2A recommendation, so it is a weaker recommendation. So therefore, in practice, I don't think this is widely practiced in Australia. However, personally, I think there's a subgroup of patients who benefit this more than the others. We use colchicine as an anti-inflammatory. A lot of the patient actually, with autoimmune disease, like Crohn's disease, ulcerative colitis, and other form of arthritis, autoimmune arthritis. So this patient, if they have coronary artery disease or acute event, and I would start thinking about using colchicine in conjunction with other conventional, more commonly used medical therapy. So this has made it to the guideline after many years, where I've been hearing the colchicine trial since I was a registrar, and 10 years now to track, it finally make it into the guideline. It's not quite common in practice, but it is something that I think we have neglected to some degree. So what's the sphere here? So I would like to spend a bit more time talking about adherence. So this is actually our biggest challenge. You and I mean, particularly me, we are very good at pushing, giving, and ask people to take more medication. But we also know how bad or how miserable we are in terms of keeping these people taking their medication at home. So the trial always quote up to about 50% of patients actually was not compliant with their medication after about 1 or 2 years. So that, of course, includes patients with acute coronary syndrome. Unfortunately, humans, we have poor long-term memory, and a lot of these patients actually forget how it felt when they were when they're so close to death. And then initially, we were quite well behaved for the first 12 months. As years gone by, people become more complacent, and therefore, compliance and adherence to medical therapy has a tendency to drop over time. So one of the things that I always like to do when I see them in my consult and when I see them once a year or once every 2 years is, are you good at taking your medication? Are you missing them? Is there anything you want to talk about? And because compliance is something that we assume they do, and sometimes we don't check. So if the patient has a history of non-compliance in the past, when, for example, the GP asks them to take a statin or diabetes medication, then they have neglected it, and they had an acute event, and they come back to see me. So those are the patients that I tend to blacklist them, and I'll try to keep them a bit closer. And I actually make a little note to make sure I check the compliance when I remember. And those are the patients I tend to at least see them once a year. And as compared to some of my very stable patients who are good at taking the medication, they are taking in charge, you can tell their life has changed after the acute event. Those patients who are willing to take charge, they are not having any chest pain, there's no residual coronary problem. And then those are the ones I'm actually quite happy to see every second year. So nowadays, there are more clever way of how to encourage adherence. And one of the common things I like to do is actually bring the family in. So if they are old, I like to bring that family in. If they are men, I like to bring their wives or their partners in so that we can have a conversation about the importance of taking their medications. And nowadays, there's you can set an alarm from your phone. You can use a text messaging system. There are also the different ways of improving compliance. Again, it's just something that you just need to think about it. And like any chronic medical conditions, compliance will be the hardest and the biggest problem. So just a couple of quick points about cardiac rehab. When I was in the hospital, we always emphasize very important to attend. And those who attend cardiac rehab has reduction in mortalities and mobilities. I'm not quite sure there's some selection bias there, but importantly, the knowledge, the change of attitude, and the good advice are important guiding through these individuals. One thing that we do tend to talk about in the hospital is when the acute event occur, it happens so quickly. A lot of patients actually stunned and they actually doesn't absorb of a lot of the information we tell them in the hospital. Therefore, cardiac rehab is a very systematic way of covering all the essential information and the exercise strategy and change of lifestyle the patient need to know. So ideally, all patients should be booked before they leave hospital, but we know sometimes they are missed. In the past, at North Canberra Hospital, it was quite easy. The patient actually can self-referral. But nowadays, looks like, at least in Canberra Hospital, you all have to go through the central health intake referral, which is a bit of a pain. I suspect the North Canberra Hospital may end up changing in the future as well. But again, the cardiac rehab nurses are very helpful. They are good resources and do encourage your patient to attend the cardiac rehabilitation, especially the younger group of patients. I find that in general, patients in their 60, 70, 80 that tend to be quite liking to join this. But the younger patient in the 30, 40, or 50s, and those are the ones that probably need a little bit of encouragement. And this graph, I thought it just provide a big overview of a lot of the things that we have to talk about when we see the patient. So therefore, as you can see, there's a lot GP and including cardiologists we have to do to make sure we keep them on the right track. So these acronyms of healthy diet, exercises, achieve normal weight, leave smoking, take control of blood pressure and cholesterol, handle alcohol, and yield to stress management. So I believe we are all part of the key role here to keep our patient on the right track. And we have to think the person as a whole and to look for and influence every single part that we can improve their positive health behavior to achieve a good outcome. So just a simple couple of points about lifestyle counseling. I would like to touch on the importance of avoiding the seasonal respiratory infections. We all know that influenza has increased mortality for patients, and patients with coronary artery disease, they have higher mortality when they have influenza. So this fall onto your burden to make sure patients with coronary artery disease, they get vaccinated, okay? Very common in the community is sleep-related breathing disorder, sleep apnea, central apnea. Those are the things that if you think the patient has the usual phenotype and therefore referral for sleep study would be a good thing to do. Sexual activity, and it's not an uncommon question that we get asked after acute infarct. So in general, we consider sexual activity as low cardiovascular risk for stable patients who are not symptomatic at low to moderate activity levels. What it means by that, post-event, usually the patient will ask me, when can I resume? I'll say, when you can exercise without significant symptom or chest discomfort. So therefore, I would say, go for a half an hour walk to the level when you're slightly breathless, but can still hold a little bit of conversations. And if you're not getting any chest pain walking up that 2 flights of stairs, then you're almost ready to try. And the use of tadalafil or sildenafil, the PDE5 inhibitors, are generally safe, but I always give them the red flag. If you use the medication and you get chest pain and you call an ambulance, you have to tell them, do not give you the GTN spray or the nitrate lingo tablet. Otherwise, their blood pressure can plummet to a dangerous level. So that is the main precautions. Otherwise, if you use it and you get chest pain, then you stop until you come back to have a chat with me again. Psychosocial, this is actually an important part. Anxiety, depression, post-coronary syndrome is very common, quoted up to about 30 to 40%. Therefore, managing those emotions is important because if left untreated, they can lead to discontinuation of medications and bad outcome. And we generally say avoid psychosocial stress, but easier said than done. A lot of it is work-related or familial related stresses. Important point about pollution and environment, avoid passive smoking, reduce noise, and avoid exposure to air pollutions. So smoking cessation, I think, again, is one of those topics that's easy to mention, but hard to do, hard to implement. And I'm sure you guys have been doing a better job than most cardiologists in asking patients to stop smoking. But we do know that if the patient can stop smoking, there's a significant reduction in risk of premature death and compared to those who continue to smoke. And the measure to promote smoking cessation, such as the quit line, the helpline, behavioral intervention, and pharmacological therapy. You guys are all very familiar with the nicotine replacement therapy, the Champix and bupropion, which is Zyban. They're all effective and they are not linked to an increased risk of major cardiovascular event. Another difficult topic is weight. So in general, we like them to achieve the best possible weight. And this target in a lot of my patients will be unrealistic. So I usually say, set yourself a small target and just 0.5 kilogram a month. And then if you can achieve 5 to 6 over a year, that's a win for me. All right, just something very small, something very achievable. And in general, I always say there's no specific diet that I would recommend because none of those diets, if they are not sustainable, they are not going to have a long-term good effect on you. Of note, those individuals who like what they call the carnivore diet, which is a saturated fat dominant diet, those are bad. Those actually create bad cardiovascular outcome. Even though some of them may lose weight, but there's a kind of the bad weight loss that we don't want. Reduction of weight can be achieved through lifestyle, diet intake changes, physical activities, but they also include potential pharmacological and surgical intervention. As I mentioned before, the GLP-1 receptor agonist is considered safe from the cardiac point of view. And diet and alcohol consumptions, again, alcohol, the European Society guideline about 100 grams, which is 10 standard drink a week, which is somewhat similar to what we say, not more than, 2 to 4 consumption each time and have few alcohol-free days. Again, diet high in fibers, whole grains are considered a better things to have. In general, I just say use a food pyramid. Whatever at the bottom, that's good for you. Whatever at the top, that's for special occasions. We aim to have reduction in saturated fat intake. Physical activities, again, we always say 30 to 60-minute moderate intensity activity or more than 5 days a week is a good thing to do. Apparently, according to research, it's the reduction of sedentary time that's important as well. Even just go out for a gentle walk is much more beneficial than sitting on the couch and watch TV. So in Europe, they recommend at least 150 to 300 minutes per week of moderate intensity activities, or a bit less, 150 of vigorous intensity activities throughout the week. So therefore, when we say moderate intensity, nowadays I finally understand what the easiest way to describe to patient is exercise to the degree where you're slightly breathless, but you're still able to hold a conversation, and that's considered moderate activities. Vigorous, when you are so breathless, you can't talk anymore. That is intense physical activities. So in terms of long-term follow-up and check, asymptomatic patient with established coronary artery disease, regardless of symptom, should have a periodic visit, at least annually, to a general practitioner or cardiovascular healthcare profession. So that means I would suggest the patient to see you guys, a general practitioner, on the annual basis, and for one consultation to be dedicated to go through their cardiovascular management. And some of these patients, if I have concern, as I mentioned, if they have chest pain, sometimes I see them every 3 to 6 months until they're stable. If they have underlying coronary artery disease, sometimes I see them every 12 months, just in case they changes. If they are fully revascularized, they are good kind of patient, they're compliant, then I tend to see them every 2 years. The reason to bring them back every 2 years is just in case if we have new therapy available, and some of these patients, I can still capture them and institute some of those changes. In general, I see myself as just a reminder for the patients. When you come and see me, usually they would slightly pay a bit more attention. And then if they have missing a few important medication, that's when I have a second education with them. And hopefully that will be able to make a difference. But I think in general, they should be doing that with you guys on a yearly basis. And 6 monthly, fasting lipid profile, sugar check, I think that will be a bare minimum. So symptomatic patient with established coronary artery disease, occasionally some of these patients, we will need to reassess them. For example, if they have more angina sounding chest pain, or if the LV function start going down. So usually my own practice is I would like to do an echo every 2 or 3 years if they are stable. If they're stretching longer than that, they have no significant symptom, that's probably okay. But every 3 or 4 years will be the longest stretch I would suggest in terms of echoes. If patient has worsening symptom, then we start thinking about functional imagings. So one of the thing about imaging and which modality to use is slightly more complicated for patient with established coronary artery disease. A lot of the imaging places in Canberra, they are not quite well trained to do CTCA for patient with stent. And therefore, sometimes the result can be a bit more confusing. In other high volume centers like Monash Heart and some certain New South Wales centers where they are quite familiar in reporting CTCA on stent, then CTCA might be a potential things to do. CTCs is particularly good though for patients who have bypasses. When we're thinking about graft failure, then the graft that has been done 10 years ago, is it still patent? I think the CTCA actually is quite a good modality to do that. In general, if the patient having chest pain, our routine things or common thing that we do is a stretch echocardiogram. If they can exercise and they are not too big, because the echo images really is dependent on the chest wall of the patients. If we can't do a stretch echo, sometimes we do a functional test, which is a myocardial perfusion scan, but they have higher radiation dose. They are also more expensive as well. So I usually reserve those for individual who can't exercise at all. So when should patients see cardiologist sooner? So for example, I always say to the patient, I say 12 months or I say 2 years is with the assumption there's nothing wrong. If you had new problem or your chest pain get worse or there's some issue with your medication and there's some concerning changes or you need surgery or some other things that may be challenging you, of course, that is when the patient need to come and see the cardiologist sooner so we can make another reassessment, whether or not we need to reassess the coronary arteries or whether or not we need to change the medication and so on and so forth. Again, they are stable until they are not. So therefore, technically speaking, all the coronary artery patients, they are not stable because any of them can destabilize at any point. And I always say there's never a test that I can do to guarantee that you can't have a heart attack because plaque rupture is something that we can't predict. Therefore, even a minor disease or 20 or 30% can still kill you when they fully occluded the artery with a thrombus. All right, with that, I open to questions and just feel free to ask anything. I will try my best.
Okay, fabulous. Thank you. So we've got a question about the maximum dose of rosuvastatin in Asian populations.
Right. Actually, I don't have a specific experience in that, but in general, I haven't noticed a big difference of the Asian patient that I treated in Australia. I find that in general, the response is somewhat similar. Because the level of cholesterol is actually quite similar to the general population. I don't think there's a big difference. In terms of dosing, I mean, potential susceptibility to side effect, I'm not observing any specific race differentiation, put it that way. From my point of view, highest tolerated dose is the best. Even if your LDL is less than 1, I'm still quite comfortable nowadays to continue the same dosing. Yep.
How often after a change of statin dose do you
Yep.
test?
So,
Or how long after you've changed the dose?
I mean, generally speaking, I like to say 3 months. In
Mm.
fact, you probably can see the difference after 6 weeks. But I just, for convenience, I say just 3 months. But if you want to check the early result, by 6 to 8 weeks, I think you should get a sense of what's happening. Yep.
And once they're in the kind of right time, the right bracket for their cholesterol, is it
Yep.
an annual test or would you still say 6 monthly with the GP?
Okay. So annual test, if the patient is compliant. Sometimes I do the 6 monthly. Mainly if I have suspicions, the patient may sometimes slack off. Then I think the 6 monthly test is probably better in that group of patient where you are a bit suspicious. But if the patient has been stable for 5 years, 10 years, they are good at taking their medication, they're always spot on. I think yearly is probably reasonable.
Right. Thanks. And so we've got another question. This is about the PDE51
Yep.
medications. Why? So as we probably remember, they were originally developed for hypertension. So why aren't they used for hypertension anymore?
Okay. I think partly because we have better antihypertensive. The drug do have other side effects as well, and fluid retention is just one of them. It's interesting you mentioned that because they are not the PDE inhibitor per se. There are others vasodilator being considered for patient in heart failure. So therefore, the space is quite a fluid things. In general, just they are not particularly a good antihypertensive is the main reason. They are good pulmonary hypertension medication, for example. So we do use a lot of the sildenafil and tadalafil in combination with bosentan, macitentan, the kind of medication for PAH. So I don't think the drug is needed as an antihypertensive. They actually have more effective use in the endothelium type situations. So we probably don't need them in that sense. Yeah.
I was just wondering, so how does colchicine work? Does it stop inflammation in the plaque?
Yeah. Okay. So this is an interesting one. Not until about 5 years ago, we always believe inflammation is a big part of atherosclerotic process in theory, but we never has proven in clinical trial that treating inflammation make a difference until about 5 years ago. I can't remember the name of the immunotherapy. So there was an immunotherapy that was used in the randomized control trial. For the first time, it reduces cardiovascular event. However, the benefit was offset with increased risk of infection. But there was a proof of concepts kind of study. We hope the anti-inflammatory therapy would open up a new front in terms of coronary artery disease treatment in the future. And colchicine is a good old drug that has been proposed or has been hypothesized that the anti-inflammatory benefit of the colchicine can achieve the same thing. So after many years, they all started as a very small trial in Western Australia. I think there's quite a number of them that's become quite famous, and a couple of them from Europe. And after all these small trial combine, and there's a signals towards good effect of colchicine in long term for coronary artery disease, not for pericarditis, but for coronary artery disease. So again, it's quite exciting because who had thought, a simple old drug can be beneficial. So it has come out as a weak recommendation because the trial are quite small. But in my opinion, if patients have chronic inflammatory condition, that will be the drug that I will start thinking a little bit early on. Yeah.
Right. And so conversely, why is it that things like non-steroidal anti-inflammatories raise your cardiovascular risk?
Right. So I think the anti-inflammatory is a bit different. They are not anti-inflammatory to the actual inflammation itself. It's more the effect of that. So one of the problem with anti-inflammatory that we normally use for painkiller is the fluid retention and the hypertensive effect. So those things are actually detrimental. So in fact, they're actually quite not a good kind of anti-inflammatory from the cardiac point of view. And that's why they are bad for the coronary artery disease. They are bad for heart failure patients.
Right. Yep. So I think that's the questions for tonight, unless anyone else has got any burning questions. I just want to thank Dr. Siang So for an amazing talk that was very straightforward and simple and really useful, and it was also very up to date. And just to let people know that we'll put a copy of this webinar on the Capital Health Network YouTube page in a couple of weeks. Please fill in your evaluation surveys that will be sent to you shortly, and feel free to self-report. I know it went for an hour, but 1.5 hours of educational activities. And thank you so much, Dr. Siang So, for presenting tonight. The next webinar is on the 6th of August, so please register for that. And that will be Sharon Wilson, Dr. Sharon Wilson, covering heart failure. So thank you very much and good night.
Thanks, everyone.
Thanks.
Thank you.